and welcome to today's webinar, A Vascular Access Approach to Infection Prevention, where we're going to focus on COVID-19 or the coronavirus. I'm Judy Thompson, the Director of Clinical Education for the Association for Vascular Access, and we're glad you can join us.
Well, good morning to each of you, and thank you to all of our healthcare professionals and industry partners that have taken time out of your busy schedules to join us this morning for really what is a hot topic. And I know several of you have already sent in questions. On the right side of the screen, you'll see that Judy's already loaded some handouts. There is an ebook there that has CDC resources that are available in PDF, as well as your QR code, which she'll go over at the end of the webinar for CE. There is a third handout that will be provided to you, which is the slides. So that will be forthcoming as soon as the webinar is over, that you'll be able to download. If you do have any questions as we go through the program this morning, however, I'd love for you to submit those in the chat box on the right. And Judy and I will go ahead and manage those as quickly as possible for you as we go through that. So since we are offering continuing education, here are my disclosures to make available to you. And our objectives for today are really to look specifically at the global and domestic status of this outbreak, and frankly, to calm down the hysteria. You know, there's sort of a phrase in infectious disease, never let a good outbreak go to waste. And so every outbreak that we have, or every infectious disease challenge that we have, is really a matter of what do we learn from it? What do we do to take that forward to the next one so that we're more prepared than we were the day before? We're also going to look at some common sense approaches to ensuring that our work is safe. We recognize that these patients that are hospitalized with a COVID-19 infection do require some advanced therapies. They're going to need vascular access. They're going to need intensive care support, especially if they have pneumonia and other comorbidities. And lastly, we're going to look at what are some of those basic infection control strategies to not only drive safety for us as healthcare workers, but also equally important for our patients. So I do want to mention a quick disclaimer that this information is current as it can be. Judy and I literally updated these slides last night. That being said, if you watch the news, of course, you see how fluid and dynamic this situation is. This is not a virus that has me concerned, to be quite frank. It is a virus that I think is, you know, a natural evolution that we see every few years with something new and novel. But the CDC has done a tremendous amount of work in making resources available on the website that's listed there. They update that every single day, sometimes twice a day. And they have also been updating it on weekends as well. And so the information contained here is not meant to be construed as medical advice, but really to serve as sort of a framework to make sure that we have the right tools, the right knowledge, and the right resources in order to fight this. But you're always going to want to consult with your local health department for specific guidance. So what are my objectives for you today? Well, number one, I want to make sure you leave here feeling that you can be safe in performing your role as a vascular access professional. That's number one. Number two is, how do we make sure that people are not unnecessarily hospitalized? You know, are these people that need to be in hospital? Can they be in the home health environment? How do we keep our patients safe? And probably the most important one is, how do we make rational and pragmatic decisions based on the current available evidence that we have for us? And I think that's really, really important, that we don't overreact to this situation. Judy was joking about, you know, the toilet paper issue. And I live here in Atlanta, and there is no toilet paper. It is the most amazing thing that I've seen in a long time. And so we want to sort of calm this down and think about what are some of these common sense things that we can do. I wanted to start with sort of the federal response to this issue. Currently, there are thousands of CDC and other agency employees deployed, and they really have four main goals. One is to stop the, obviously, outbreak by reducing mortality and morbidity. They obviously want to really look at the sort of risk cause analysis. How is this spreading in the community? What can we do to protect our healthcare personnel? And most importantly, they have a tremendous role in ensuring that the healthcare system as we know it today, that entire continuum of care, can continue to function and deliver for the patients that we have. The risk profile for COVID-19, which is what we're calling this, is pretty low, especially for people that are not immunocompromised, do not have multiple comorbidities, and are appropriately using PPE. And so this sort of ridiculousness of everybody running out buying masks and walking around wearing the same mask for days is completely absurd, to be quite frank. We, again, want to make pragmatic decisions based on available evidence. We want to reserve personal protective equipment for you, the healthcare providers, that will be potentially in harm's way of exposure. And so then using that PPE appropriately is really, really important. We also want to think about how can we mitigate transmission. So if you've watched Dr. Fauci from the National Institutes of Health on the local and national news channels, you've seen that he's made a couple interesting recommendations. If you're older, maybe avoid places where there's going to be a large amount of people. If you have a lot of comorbidities, obviously not the best time to travel. He specifically said, don't travel on cruise ships right now until they get a better handle on this. And so these are all some scientific pieces of information that the government is offering us. But we do recognize that you as a healthcare worker that might be caring for patients with COVID-19 are certainly at an elevated risk. Now, can that risk be mitigated and managed and screened appropriately? Absolutely. And then we want to look at sort of that travel history. Now, when we started this back in January, there were some pretty limited geographic spots that we had to be concerned with. And when we think back to a couple of years ago with Ebola, we had some very specific geographies that we could really hone in on, and that has sort of changed now with this COVID-19 outbreak with the number of countries that are affected. So I wanted to give you an idea of where we are as far as current status. So this is as of yesterday at 5 p.m. The total number of cases globally was roughly about 110,000. And again, this was at 5. I'll show you something else here in just a second. The total number of deaths globally was, close to 4,000. And in the U.S., there were 554 cases. This is a map that Johns Hopkins has produced, which I absolutely love. It's an amazing tool. This is something that if you want access to it, you can go out and Google Johns Hopkins COVID map, and it comes up, and it's a live feed. They've done a phenomenal job. So on the left side, you can see the total number of confirmed cases, along with a breakdown by country. On the right, you'll see the total number of deaths, and you can actually zoom in on specific locations, especially in the U.S., and see down to the county level where are these reported. So the link is included at the bottom in case you're interested in that. And again, we fully anticipate as more test kits go out that we will continue to see an escalation in the number of cases. That has no relevance necessarily on the infectivity of it, nor the risk for community transmission. The number of cases alone, again, is not going to be indicative of transmission. It just means that these cases have tested positive. And again, as we increase surveillance as well as access to testing kits, we will continue to see that. So your facilities, especially if you're in the hospital environment, you'll see more and more of that. So this was another link that they put out looking at total number of deaths. And so this is available on the website that's listed there on the right, and you can actually zoom into the U.S. Information at any time. So when we look at the breakdown of COVID-19 cases, we have seen obviously a lot under travel-related category. We're now seeing an increase in the community spread of this, especially in New York State and some of the other places. And for those of you on the West Coast, you've certainly followed the incident right outside of Seattle. And so we do anticipate to see more community spread. Under investigation, as these test kits are continued to be sent out into the communities, and especially as private reference laboratories increase their capabilities to offer these tests, again, we'll see these numbers grow. So what's the clinical presentation of these patients look like? So I think we want to start there. Well, obviously they're going to be febrile, they're going to typically have a cough, and a lot of times they'll have some type of shortness of breath. These patients, the ones that are hospitalized, are typically presenting with pneumonia as a chief complaint, and so that's something for us to think about. The incubation time period is estimated to be around 4 days. However, we know that with MERS and SARS, and of course this is a form of SARS, it's 2 to 14 days. And so when we think about sort of the differential diagnosis of these patients, it's very similar to other things that we're dealing with, especially flu, which we still have circulating. And then the sort of less common symptoms are things like cough with sputum, headache, and sore throat. And again, as CDC learns more about this and gets more clinical information as they're collecting these specimens, this information will be updated. But again, we're really looking at a typical respiratory transmission. We're looking at a respiratory virus. We're looking at things like how do we keep the environment clean? How do we maintain hand hygiene? What personal protective equipment is necessary? And how do we keep ourselves safe so that we can continue to care for the patients that desperately need our vascular access services? The case fatality information to me is fascinating. When you look at those with no underlying medical conditions, so no comorbidities or anything like that, the case fatality is less than 1%. And that's of course in the U.S. When we look at that compared to China, as high as 49%. So as you can see that I've listed there, different types of comorbidities certainly increase that potential risk to that patient. We certainly recognize that chronic respiratory disease is not good in this situation, but again, this is very, very similar to the case presentations that we see for other viral illnesses that are respiratory in nature. From a hospitalization standpoint, we're really looking at patients with pneumonia that are typically requiring hospital care. Many patients are able to recover on their own with limited or no symptoms. And typically they're finding, CDC has found that in that second week of illness is where some of that clinical deterioration takes place, which is pretty interesting. So that's really where that 14 days comes in, especially, is to make sure we're going on the end, if you will, of that incubation time period. And, you know, acute respiratory distress syndrome is also a chief complaint here related to that pneumonia. So there is diagnostic testing available, and this is a little bit of a moving target here, but there is a validated test that CDC has sent out to state public health labs. They are now in the process of actually commercializing that, so laboratories like Quest and LabCorp will have access to that, as well as other regional reference laboratories, to make this testing more readily available. So we will be slowly moving to that over the next few weeks. If you watched any of the news outlets, you've seen that CDC has been under a tremendous amount of pressure to increase their volume. I will tell you, as somebody who has tremendous respect for CDC and works with them on a regular basis, these folks are doing everything in their absolute power to mitigate risks. They've got tremendous amounts of staff deployed. There's essentially no one at the agency that is not somehow touching this outbreak. In support of being in the field, answering phone questions, doing diagnostic testing, and frankly, making sure good, accurate information is presented to the public. And so this is something where state public health laboratories are tremendous partners in this, and working with CDC to help us move that needle forward. The virus itself is called SARS-CoV-2. Again, we're looking at a primary spread via respiratory droplets, particularly among close contacts. So if you're 6 feet away from somebody, the chance of this spreading to you is very minimal. We're also looking for that prolonged period of time as well. This is really, really helpful. And then when we look at body fluids, we want to make sure that if it's wet and it's not yours, it doesn't touch you. That's one of my colleagues always says that, and I love that phrase. So personal protective equipment, protecting ourselves from mucous membranes, is really, really important in order to do that. So as far as routes of transmission, I wanted to expand. I know several of you, I know Mark sent in a question about this as well. We're not just looking at mucosal transmission. So we're not just looking at your mouth, your nose, and your eyes. We're also looking at environmental surfaces. And so when we think about the major tools that you use as a vascular access expert, you're using probably ultrasound, you might have a cart, you may have other supplies that you're taking into a room. Maybe you're using some type of EKG machine for placement confirmation. Maybe there's a portable radiology piece of equipment. These are all things that we have to think about on a daily basis, right? And again, much of what we're talking about is not at all new. It's something that we should always be doing as sort of our general plan of attack, if you will, for emerging infectious diseases. So if I think about, I walk into a patient room, I greet my patient, I'm doing my hand hygiene, I'm ensuring my environmental surfaces are clean, I'm going to put my sterile field down, I'm going to open up my kit, I'm going to use my ultrasound. What do I do when I get done with all that? And we'll talk about that here in a second, but you'll find that the recommendations from CDC, EPA, and FDA are pretty similar to what we've been doing in the past, with a few exceptions. And then we have, again, seen that documented community spread, especially in some of these different cluster places like New York and Westchester County, where there has been a pretty widespread community exposure due to close proximity contacts. So as far as risk, again, if you are symptomatic, that is when we know you are most infectious and most risky to others. But there is some evidence that people that are asymptomatic can potentially transmit the virus. And again, that's very, very limited. So we want to focus on our core practices of infection prevention and control. We want to stay home when we're sick, number one. We want to focus on our hand hygiene, make sure that we're doing that deliberately and after every single encounter. We want to keep our environment of care as clean as possible. We want to remove pieces of equipment that might be contaminated and make sure that they're properly serviced if they're not functioning well. We want to use PPE appropriately. And lastly, we want to think about, how do we introduce engineering controls and also collaborate with our public health authorities to ensure that we keep a handle on this. When you look at other countries, like what Italy is going through right now, Iran, certainly China, the U.S. has done a far better job from a public health perspective of trying to mitigate this. And so we've got always work to do and always opportunity to grow. But what we wanted to do in today's program is to arm you with some good information so that you could properly care for your patients that desperately need your services. Community spread, the definition from CDC is people that have been infected with the virus in an area, including some who are not sure how or where they became infected. So that's pretty self-explanatory. And again, we will continue to see this, especially in large gatherings. I know Judy and I were talking when the program was starting before everybody joined about how many medical conferences have already canceled. I know 5 have canceled that I was planning to attend in the last week alone. And I think we'll continue to see that. Do I personally think that's necessary? Probably not, as long as good infection control measures are introduced. But again, we're living in sort of this state of perpetual fear, and there's really not a lot of reason for that. And so we want to make sound decisions that are based in science and also rooted in what we should be doing each and every day, so that it's not about COVID-19. It's more importantly about what do we do every day to protect ourselves and our patients from potential infectious illness. There are at-risk populations that CDC has identified. Certainly older adults has been all over the news, but then again, those people with those chronic comorbidities like heart disease or lung disease, certainly if they're immunocompromised, so think about our oncology patients, our HIV or hepatitis patients that are certainly going to be a little bit weakened in the immune department. And right now, children and women are not being nearly as impacted as we would expect. So there's a couple of basic things that we can do to look at essential infection control risk approaches, if you will, to mitigate risk. The first one is really to minimize the chance for exposures in the first place. How do we ensure that we're adhering to personal protective equipment? And this is where it gets a little dicey because nobody likes PPE. And especially if you're adding into the mix an N95 respirator, which may or may not even be available to you right now, that is another level of barrier protection that can cause, let's just say, a little bit of angst when you have to wear it for a long period of time. It's not the most comfortable device. And then what can we do to mitigate flow of individuals in and out of our facilities? If, for example, you're placing a line, you don't want to have other visitors in the room if you can, for obvious reasons. The same is true when we have people coming into our hospitals or outpatient clinics. We want to ensure that we're asking some good screening questions. If you work in a hospital environment, you most likely have access to a volunteer. If you have volunteers at your front desk, this is a great time to train them to ask these questions. Are you currently experiencing a fever? Do you have any chills? Have you had any respiratory symptoms? Have you been outside of the country? And again, we can no longer say, well, have you been to China? That's not going to be a very effective screening question today. But we can then use that information to say, okay, is this somebody that really needs to come into our healthcare facility right now? Or is this somebody that we need to defer access to until they're non-symptomatic? And again, these are all things that can be done quick, easily, and help reduce the risk. We'll talk a little bit about engineering controls. What are some of the things that we can engineer into our systems of safety to sort of root out sources of error? And then personnel. This is one that is causing people a lot of heartache. And if you've watched the stock market and the economy, you certainly can understand what's going on. There are obviously things canceling. So we have events that are canceling. We have people canceling airfare to the point where airlines are being required to actually fly empty planes to keep their time slots. So there's a lot of impact on the economy, but we recognize that healthcare workers specifically play a unique role. If you don't come to work, then there's no vascular access services. If an ER nurse doesn't come to work, then the ER is understaffed. Or if your intensivist is not able to get into work due to illness, then you have all these different compromises that take place within the healthcare system. So it's critically important that we manage our personnel that might be exposed, that were definitely exposed, and that might or definitely become ill, so that we can recover them as quickly as possible and also mitigate transmission amongst ourselves. And then the last two are really looking at environmental infection control, which I'll touch on here in a second, and then working collaboratively and proactively with our public health authorities. These are our experts in stopping disease transmission. That combined with your in-facility infection preventionists, if you are in a hospital setting, these are your allies, working collaboratively with them to say, what are we doing? What can I do to help? And many infection preventionists are on this call today, so we certainly welcome you as well. What are some things that we should do before the patient ever arrives? Well, if you're doing something electively, so of course some of you this may not apply directly to, we want to call them and ask questions ahead of time. right? Obtain that travel history ahead of time. Think about those with symptoms. Are these people that we absolutely need to see? I'm thinking specifically, I know one person asked about an oncology patient. Well, there are certainly ways that you can mitigate risk. We recognize, for example, that people that have dialysis have to have dialysis. If they're on some type of oncology treatment, they have to have that treatment. So we'll have to work as quickly as possible to address some of those scenarios, but also ensuring risk. Are there private isolation rooms that we can treat these people in, where we can mitigate transmission and also keep them safe, especially if they're immunocompromised? Once they get there, right, if we can, and we have a potential patient, so let's say that you're going up to care for a potential rule-out patient of COVID-19 in ICU, is that room negative pressure? Do you have access to N95 mask in order to wear? Have you been fit tested for those things? You can also post signage, and there's a lot of free signage. I included that in the ebook that's on the right side, so if you want to download that, you'll find that, as well as you can certainly click on the links to the CDC page. They've got communication tools that we can use to have those conversations with our patients as well. And then, just like we do every fall and winter, remind ourselves and our staff members about cough etiquette. Don't cough on other people. Don't cough on equipment. Cough into your elbow. If you're symptomatic and you have a fever, stay home. And then if we can, make sure we have a well-ventilated space in order to work that's got that sort of 6 feet of clearance. So what can we do to protect ourselves, our workforce that is required to go in to care for our patients? Well, again, we can screen patients and visitors. We can also screen employees. So if we have somebody that's coming back from vacation, this is a human resources area that needs to get involved and say, can you tell us where you went? Were you outside of the United States? Because if somebody says, hey, I went to Westchester County in New York for vacation for a week, and I, was shopping and I was doing this and that warrants a very different conversation than I went to a Caribbean island where there's been 0 cases, for example. But then you've got to also think about airfare and all that kind of stuff. So we always want to think critically through the situation and say, what's the most appropriate thing for us to do before that person returns to work? From a human resources standpoint, if we can have good, solid HR policies that actually encourage our staff members who are legitimately ill, I want to say that clearly, that are legitimately ill to stay home if they're ill, especially if they're febrile. We do not want these people at work to risk infecting the rest of our workforce. Certainly, we understand staffing challenges are real across healthcare in every sector, but we also want to ensure that we don't wipe out our workforce with a potential infectious illness, especially the hysteria that would send through the news media and to the public that us as healthcare workers are then, transmitting to patients. And then you can look for that workplace illness and monitor that. If you see sort of a cluster of nurses, for example, in a specific area that are out for illness, is that truly related to a respiratory symptom? Is that something else? What may it be? And so again, we want to work with our infection preventionists to do that. So let's transition and talk about personal protective equipment. We're recommending our standard precautions with some enhancements here. So we're going to look at our regular gloves, a disposable isolation gown or coveralls. A gown, honestly, is perfectly fine. A NIOSH-approved particulate respirator, such as an N95. Eye protection, again, we're trying to protect our mucous membranes. So, the reason that this is an N95 is that there's been some limited evidence of transmission of the particles in the air. We don't know how long it stays in the air, and so out of an abundance of caution, CDC is really looking at this. And so they're trying to be very aggressive in understanding to do that. If you have somebody who is wearing any type of gear, so I know several of you asked about public safety. So I've included a comment in here from the new guidance for public safety for CDC that all of that gear, like their duty belt, needs to come off and be disinfected with an EPA registered hospital grade germicide, which we'll talk about what the requirements for that are here in just a moment. As far as gloves and gown usage, we want to make sure that we're going to put this on correctly and remove it correctly. And certainly if the gloves or the PPE becomes torn, just like always, we want to make sure that we remove that and put on a new one. Hand hygiene does not go away simply because we use this PPE. As a matter of fact, we need to do more hand hygiene because PPE gives us sort of that sort of false sense of security related to that. And any disposable gown should be discarded after use. And so I totally recognize that we're in a pinch right now from a supply chain with PPE. And so work collaboratively with your hospital's infection preventionists if you're in a hospital environment. If you're in the outpatient environment, call the hospital and ask to speak to the IP and ask them for their best guidance on if there's any resources they can allocate or what their recommendations would be. And again, your infection preventionist right now is your best friend. From a respiratory protection standpoint, if you're wearing an N95, you should be fit tested. So we want to make sure that that's going to fit. For men, if you have facial hair, this can cause a poor seal. There are great videos out there available. If you click on that link there, you can go directly to the NIOSH website, and there are respiratory training videos that are accessible for free. I would highly encourage you, especially if you're going to be interacting with these patients, to go and watch those videos to make sure that your employee health department fit tests you so that you do have an appropriately sealing mask to protect yourselves. The great news is that if we use PPE appropriately and we identify these patients and we sequester them, we're doing a good job of stopping transmission. It's when we're not doing those things that we have potential risk. And again, I think we all learned from Ebola, mass hysteria, mass reaction, and we went back to we need to more appropriately know how to use PPE. We need to know our workflows and our processes, and we need to think about that human capital aspect of this equation. So when we're using that respirator, again, it needs to be CDC or NIOSH approved. It needs to be for use in healthcare. Yesterday, I got a phone call from a public safety department that was asking me about coronavirus, and they said, well, we went out and we were able to talk to the manager at the Lowe's, and they've given us 3 respirator masks. And I said, well, send me a picture of it. Let me see what you're talking about. And it was a sanding mask. And so again, there's a lot of confusion out there related to what's appropriate. I will say that on Friday, CDC and FDA released a new list of other approved masks that can be used in a pinch. Judy will make that link available in the follow-up email to you. That list may change as time goes on, as more manufacturers get engaged with this. With most of our PPE being manufactured in China, you can imagine that's not a good position for us to be in. We do, however, want to ensure that this respirator is going to protect our face and our respiratory passages so that we can minimize potential airborne exposure. When we're using that face mask, it needs to be one that's cleared by the FDA. This is really, really huge right now. I signed on to Facebook last night for something else, and I got just pounded by people that were saying, I want you to check out my mask. I want you to check out my mask. And I stopped looking after the 6th one because I went to the FDA's website, and none of these are approved. These are all fake counterfeit masks that are being sold. So if you're involved in your value analysis committee, certainly your infection preventionist is going to be looking at this as well. Make sure you're purchasing stuff that is legitimate and is going to keep your staff members safe. We do not want to be in a position where our colleagues are injured or hurt because we're using materials that are not designed or approved for use in healthcare. And again, FDA and CDC do advise that the mask not be reused. Again, understanding that there are issues right now with mask availability, you can consult with your infection preventionist to determine what is your plan. There's other things like PAPRs and stuff like that that might be available. From an eye protection standpoint, simple, we want to make sure we protect our mucous membranes. That includes our eyes. I know the latest statistic I saw was that men touch their face 2,500 times a day, which is frightening on every level. And I stopped counting one day because I got so close to 2,500 times, and I'm thinking this is insanely ridiculous for risk of transmission. But if we protect our eyes, we protect our mouth, and we protect our nose, we have a very decent chance in ensuring that transmission stops and is not going to continue forward. We also want to ensure that anything that we come in contact with, whether it's lead wires, ultrasound, tables, blood pressure cuffs, stethoscope, anything that we're using in the care of these patients, that we're appropriately disinfecting it after every single use. When we're doing aerosol generating procedures, this is where we have increased risk. So if you're in a room and they're doing some type of procedure, I'm just hypothetically throwing out bronchoscopy as an example, and maybe you're coming into place an IV or a PIC or something like that, make sure that you have a good ventilated room that is going to remove this stuff from the air and that you're appropriately protected with your PPE. Intubation is another one here that I think about, or respiratory treatment. So several of you have asked about environmental infection control recommendations. And so I wanted to sort of hit on this and also tell you about some evolving information related to this. So first and foremost is that if possible, we can use dedicated equipment, if possible, recognizing that that is certainly not very possible in a lot of times in the vascular access space because you have limited machines and things like that. If it's non-dedicated, non-disposable, we want to disinfect that and clean it after every single use. And going back to our general principles of cleaning and disinfection, if we have something that's visibly soiled, then we want to clean it first. And then we're going to follow that with the disinfection process. This is really referred to as a two-step process, again, if it's visibly soiled. We also want to ensure that whatever disinfectant we use is appropriately utilized. And so that's things like, does it have the right claims? And we'll talk about that here in just a second. And are we following the appropriate overall contact time? So for example, if the disinfectant says it kills most bacteria in 30 seconds and it kills viruses in 2 minutes, the overall contact time is not 30 seconds, it's 2 minutes. And so we always want to go with the longest contact time on the manufacturer's label to ensure we get complete efficacy, that complete kill against what we're trying to accomplish here. So this is not a time to shortcut. This is, when we refer to that, we're simply wiping or spraying that surface down, allowing it to air dry for that contact time prior to putting it back in use. If you're in an extremely dry climate, you may have to use additional product in order to do that. But again, we're trying to make sure that we're safe here. CDC has been working with FDA and EPA regarding some guidance. And keep in mind that disinfectants used on environmental surfaces are actually a product, if you will, of the EPA. So they're regulated by the EPA, and they have put out specific emerging viral claim information. And so when you see there, it'll say a product, whatever, has demonstrated effectiveness against viruses similar to COVID-19 on hard, non-porous surfaces. So, we want to look at, is this product compliant? I will also be providing you a link to products that have met this threshold from the EPA's perspective and are appropriate for use. If you can't get those products, that's fine. There's this guidance statement that says use what you have. That's EPA registered. But if you are able to, and you'll find that probably 80% of what you're using in healthcare now has met this threshold from the sort of the big guys out there on the market. But you do want to consult this list, work with your infection preventionist and also your environmental services director to ensure that you are using an appropriately claimed product, if you will, that's going to be good for this. As far as hand hygiene, no changes in recommendations here. Again, we're using our alcohol-based hand sanitizer with an alcohol content between 60 and 90%, particularly because we're talking about viruses today. There are two types of alcohol-based hand sanitizers. There's one that's more common, which is ethyl alcohol, but there are still some isopropyl alcohol products on the market. They're limited, but you want to ensure, especially for this, if possible, that whatever you're using is an ethyl alcohol product. Two reasons. One is that it's going to have less drying of the hand. So with repeated use, you're going to have less risk of contact dermatitis. But more importantly, you actually have better viral activity with ethyl alcohol than you do with isopropyl. And again, if hands are visibly soiled, just like we talked about with surfaces, we want to clean those first. So if our hands are visibly soiled, we want to use soap and water. It's not that the soap itself is better. It's simply the friction and the removal of that gross organic soil from the hands. And there is a list of products that have met this threshold. You are not going to find either on a disinfectant or hand hygiene product, you will not find on their label that it kills COVID-19. It just simply won't be there. The way that the FDA and the EPA look at this is they look at it under the context of emerging threats. And if you meet certain criteria, then you can say that this is effective for whatever that particular organism is, and that's how it works. Otherwise, we would be years behind in seeing those types of things on the label. So what are the proper steps to utilize personal protective equipment? This always confuses people. So if we're putting it on, we're going to start with our gown, then we're going to add our mask or respirator, our goggles or our face shield, and lastly, our gloves. We're then going to flip that and say when we're taking off our PPE, we're going to start with our gloves, then go to our goggles or face shield, then our gown, and then our mask or respirator. So again, there are some amazing, amazing training videos that are available if you click on this link. One that I particularly like is available through Johns Hopkins that was funded through CDC to look at what are the types of equipment that's commercially available out there, and you can select it, and then it will actually show you what's the appropriate way to put this stuff on and remove it from yourself in a safe environment. And again, much of this was funded as a result of the Ebola situation. And I want to take 1 second and really address this, that the colleagues at CDC are looking at this not just as a COVID-19 outbreak, not just as an Ebola outbreak, not just as MERS or SARS, but they look at this as how do we sort of build systems of safety for rapid response to protect the public, for rapid testing and diagnosis, for rapid treatment, which they're doing with FDA and private companies, and ensure that we're always sort of in a state of continuous readiness so that it's not, oh my gosh, today it's COVID-19 or tomorrow it's something else. it's really not about that. And I hope that you leave today's webinar program feeling very, very comfortable with the steps that you're already taking and probably take on a daily basis, with a few exceptions like adding an N95 respirator and things of that nature. But disinfection we do today, hand hygiene we do today, glove and gown usage and standard precautions we do today. Really what we're adding here is sort of just an additional layer of awareness to this is the threat of today. And so how do we use this to prepare ourselves for whatever the threat is? And I always jokingly tell people that I work with, I said, I'm not necessarily concerned about what the organism is or even a lot of details about it. What I specifically want to know is what's its route of transmission. If I know the route of transmission, then I have a really fair shake at actually being able to deal with this and stop its transmission. A lot of times that's just hand hygiene. It could be the use of PPE. It could be disinfection of a surface. So there's a lot of different ways that we can skin this cat. There's a couple other things that CDC has recommended that I wanted to share with you. Some of these you may or may not be doing already. So for example, many hospitals are pretty good about having PPE stations when you walk in, especially at your public entrances, like your main entrance, your ED entrance, outpatient, stuff like that. But I will tell you that when I go to hospitals across the country, I very routinely see these PPE stations in the corner. I'm sure that has something to do with the interior designer or decorator, but we want to have these things front and center, and we want to have screening questionnaires that are available so that when people are coming in, we're asking them these standard questions. We legitimately put more emphasis in going through TSA than we do in actually letting people come in hospitals in many settings. And that's concerning when we're dealing with potential community issues like this. And so we want to, take a hospitable approach, but also take a realistic approach to say, how do we try to keep people that might be sick out of the hospital so they don't come make our patients sick? And so these are quick, easy ways to win. We can also look at no-touch receptacles for trash. We can have face masks available at entrances. I will tell you that I would be somewhat hesitant about that particular CDC recommendation given the state of PPE availability. And so again, if you have volunteers at the front desk and somebody says, oh yeah, I've had a fever and I've had a cough, immediately have that volunteer mask that person until someone can further investigate. So maybe the infection preventionist gets involved, or maybe you have a staff nurse or somebody like that that's going to come and assist with that. But you want to mitigate the risk right up front if that person's still standing there. And we certainly don't want to contaminate other people that might be in the waiting area. We can also deploy alcohol-based hand sanitizer, which again, we do that routinely. When people say, well, I didn't know I didn't have access to hand hygiene, I very much laugh because I'm thinking that's really just not possible. We have alcohol-based hand sanitizer mounted everywhere. And yet we still have a fairly low compliance with that. And so it's reminders like this COVID-19 outbreak that say we really need to beef up our hand hygiene efforts, and not just during the month of May, which is hand hygiene month, because I sort of laugh about that and say, do we really want to focus 1 month on hand hygiene, or do we want to say we want to have a continuous effort to ensure that our hands are clean and that our patients are safe? If you're dealing with any type of procedural room, of course, keep the door shut. And if masks are not available, then you really shouldn't be performing the case. And again, you can have that conversation with your infection preventionist, but this is not an exception to the rule where you can say, well, we just don't have masks, we're still going to do the procedure. And so, that's where you would work with your local and state public health authorities. There are PPE resources available through the Department of Health and Human Services and the strategic stockpile. So there is PPE available, and it will be deployed if needed. And it will primarily obviously go to healthcare providers and public safety workers to protect themselves. There is also some mention of air exchanges. And again, since we're recommended an N95 respirator mask, I did want to throw this out there. And this is a great table that sort of says, what's your average air exchange per hour? And then what's the time to clear the room? And so working with your engineering department, they should be able to tell you this information based on the HVAC system. So that's a question as a follow-up or homework item that you might want to consider to go forward and ask, and so that you can ensure that rooms that you're using are effectively clear. And then lastly, what are some potential engineering controls? Well, we can put up partitions. We do this pretty well with things like curtains. We can use closed suctioning systems. We can ensure that our air handling systems are properly maintained. So this is, again, where environmental services, your building engineering needs to come in. And we want to try to keep these patients away from each other if at all possible. I know here in Georgia, for example, we've got residents coming back off the cruise ship from California to an Air Force base, and there are people just in an uproar about this. And I'm thinking, A, where do you think these people are going to go? They're U.S. citizens, and where better to take care of these folks than on a lockdown military base where they have the ability to sequester them away from people. And so again, we want to be logical in our approach and say, how can we pragmatically approach the problem using all available information and hardwire our infection control processes? And there's different ways to do that. We can eliminate, so we can physically remove the hazard itself. We can do things like add PPE, which protect, the healthcare worker. Are there ways that we can actually change our workflow from an administrative standpoint? Can we substitute things? And so there's a lot of different ways to do this from a human factors engineering standpoint. And in reality, we may do multiple of these things to try to root out some of these potential concerns within this particular situation. And then when we think about training, we want to move away from training and try to get a competency. How do we ensure that every person involved in this whole arena, so if it's vascular access, if it's an ER person, if it's a CNA, they need to have role-specific competency and training that says, based on your role, here's your risk of exposure, here's what we expect you to do, and here's how we're going to arm you with the appropriate training and PPE to conduct your role safely. So it's not to say that if you've got 10 patients in a hospital that's 800 beds, you don't want to have those 10 patients probably spread out across 10 floors. You probably want to segregate those people together in a locked unit where you can have dedicated personnel, dedicated equipment to care for those people. And that's just a smarter way of addressing this so that we don't put all the sick people in the same place. Places like Nebraska are doing a phenomenal job of trying to study this information. Emory here in Atlanta does a phenomenal job, and we've even got some great consultants on today's call that are experts in this field. And so it's a time to say, how do we as vascular access professionals engage other disciplines? How do we make sure that we're ready, that they understand our role, and then how can we sort of, again, hardwire some of these processes? And it can't be good enough just to educate people. It has to be a competency-driven approach based on the role. From a treatment standpoint, there is one investigational treatment that's available that's an antiviral medication that has been used through an emergency use authorization act from the FDA, but there is no FDA-approved treatment currently as of yesterday. One thing to think about for patients, especially those that you're taking care of from a vascular access standpoint, is corticosteroids are actually showing viral replication properties. And so we want to stay away, if at all possible, from that particular class of medications in order to prevent viral replication with these patients. And as we finish up and get ready for a Q&A, I see a whole bunch of questions we'll try to go through. I want to start with, we need to be cautious, but we also want to be realistic. Going out and raiding Costco and Sam's and Walmart of toilet paper is a completely ridiculous and unwarranted action right now. I understand that people are scared. And again, if we focus on our basic core elements of infection prevention and environmental control and PPE, we're going to be safe, and we'll continue to conquer this just like we do every year with the flu. And again, any loss of life is terrible, it's tragic, and it's something that we should strive to never have happen. We also want to make sure that we are educated as healthcare professionals, but also as individuals. We're all consumers of healthcare. Many of you I see on the webinar I know have kids, and so it's really about protecting your family too. And so good judicious decisions about, how do I care for these people? Can we screen them ahead of time before they come in? What do I need to do if there is an exposure, and ensuring that your facility has that approach are all things that we should be thinking about every day. Number two is, as vascular access professionals, try to screen those patients coming in if you have that ability. Ask them this information. This past Saturday, I was working a critical care shift, and there was a nurse that was transitioning care, and she said, well, the patient has a fever. And that was all she said. And I said, well, why do they have a fever? Do they have any respiratory secretions? Have they been outside of the country? And, I'm glad I asked that question, because this person actually had been. And so it changes the way that we want to think. And again, Ebola taught us some very valuable lessons. Ask better questions, assess our patients better, and really importantly, follow basic infection control recommendations, which is sort of our third point. Focus on prevention. Look at our hand hygiene efforts to make sure that we get as close as possible to 100% compliance. And remember that PPE does not negate the need for hand hygiene. It only increases it. And then lastly, look at our environment of care. Mark sent in a great question about what do we need to do for that. And just to review that as a snapshot, we need to use EPA-registered hospital-grade disinfectants, preferably that have that emergent viral claim on them. And so if you're interested in that list, we'll provide that to you. You can go check that, speak to your infection preventionist as well. And then how do we utilize this outbreak as a training opportunity, right? It's something that's not impacting every community. Yes, there are lots of cases in the U.S. comparatively, but we see many cases of other infectious illnesses each year. And we want to sort of lump those together and say, how do we focus on preventing infection transmission versus preventing only flu or only COVID or only Ebola? Because we recognize if we hardwire our processes, it really doesn't matter what the pathogen is. It's pathogen agnostic. It's really about how do we approach that route of transmission, and then what do we do to educate ourselves and our staff members about what is real and what is not. Just as a reminder, there is up-to-date information always available on the CDC website. That, again, is updated sometimes twice a day, but it's definitely updated by 5 every day, Monday through Friday. And you can always reach out to your local public health departments for additional information. I provided a few additional references for you. Like I said, Judy was kind enough to upload the ebook on the right side of your webinar system. So I'd encourage you to download that. I know Judy's going to make this recording available as well through the AVA Learning Center, so that will be available if you'd like to share that with colleagues. But these are the primary references that were used for today's program. And with that, I'm going to open it up for some question and answers, and we'll try to go through these as quickly as possible. The first one is, with the increased usage of biocides in the environment and people as a mechanism to prevent COVID-19 spread into the community, do you anticipate an increase in bacterial resistance to biocides in the near future? So it's an excellent question. So number one, we're thinking about a viral pathogen today. It is pretty rare that we see rapid evolution of these organisms to biocides. It's obviously very different than an antiviral and antibiotic. So that is not currently a concern that either EPA, FDA, or CDC have voiced. We have not seen that in the disinfectant realm. Now, we do sometimes see resistance to certain things, but primarily the biggest risk with disinfectants and biocides is if we don't properly use them. So, for example, if you are doing any type of mixing or dilution that's inappropriate, then you're going to drop that sort of efficacy, if you will, below the minimum inhibitory concentration, and that can result in growth of organisms and resistance. And so again, as long as we're using things according to the manufacturer's instructions for use, we're in a very good spot right now. So that's not currently a concern that's been voiced. The next question, this is a great one, is I'm concerned that my hospital is not providing the proper PPE. I want a full-fledged hazmat suit coverage if I'm going in to have a PICC place, especially if the PICC doesn't just drop in or I have to switch to the other arm. Right now, the little yellow gown isn't enough. My head and neck are and wrists are exposed. They're not providing head or eye protection like a helmet. So this is a pretty loaded question. So let me try to go through this individually. Remember that I said you can use a gown or a coverall. So either one of those is acceptable. If you are using a gown, it needs to be an ANSI rated gown that has splash protection. So if you, and I'm not going to get into names, but there are certain manufacturers that do produce yellow gowns. There's several of them that I can think of. And many of those manufacturers produce two different flavors, if you will. One is an ANSI rated gown that is actually rated and is OSHA compliant for bloodborne pathogens. And then there's one that's not, but they both look very similar. And so I would encourage you to contact your materials management department. Your infection preventionist would also have access to that information. So start there. But a gown is completely acceptable as long as it's splash proof. Your next part of your question is, what about head and neck protection and wrist? So this is not like Ebola where we have to duct tape you and all these other things. That is not an evidence-based reaction to this particular organism. So again, a gown, gloves, eye protection, and an N95 respirator is what's recommended. And so you do not have to cover every inch of skin. This is not something similar to Ebola from that perspective. But if you're not being provided eye protection or a mask, then you would certainly want to look at not doing those procedures because A, we wouldn't do a central line insertion without a mask in the first place from a sort of a sterility standpoint. So you really want to work with them to say, okay, if you want me to continue to perform these procedures, I'm going to need an allocation of PPE. And again, if your hospital does not have PPE, they should reach out to their local public health department for resources that are available through the strategic stockpile. So hopefully that answers that question.
Hudson, real quick,
The next,
the sterile gown that comes in the kits, is that appropriate as well? Because we need to wear a sterile gown, not a yellow gown for procedures. So
most of the gowns that are going to be in your sterile kits would most likely meet that. You can very easily find that information out by just going to that manufacturer's website and looking for their ANSI rating. If you have any questions or you need a specific piece of guidance, my email address is up there, and you're welcome to email me and I'll investigate it for you. But most of them will probably be very acceptable for that.
Perfect, thanks.
Sure. The next question is, are the masks for droplet transmission appropriate in some venues? I'm not exactly sure I understand that question, Lisa, so if you have any additional clarity, that would be great. But when we think about mask usage for the patient, a surgical mask is acceptable. For us as the healthcare worker, we want to wear an N95 respirator. This is very, very similar to what we did with Ebola, where there was very, very limited evidence of airborne specific transmission, but especially if there's going to be any type of aerosol produced. I'm thinking of a patient that might be on humidified oxygen, a bronchoscopy, a neb treatment. Any of those would directly qualify intubation. So that's where CDC is coming from, and as an abundance of caution for that. So hopefully that answers that question. The next question is, will there be additional resources available from this webinar, including handouts? Absolutely. So Judy and I ran into a little technical snafu at the beginning because we had already booted up the system. We literally were making changes to this at midnight last night to make sure that what was provided to AVA membership was as up to date as possible. So Judy will include that in the follow-up information, absolutely. The next question is, please note that without eye protection, staff will be off work for 14 days if they have a confirmed case. They need to fight for what they need. I couldn't agree with you more, Shelley. I think that's a really important aspect of this. And again, working in collaboration, hand in hand with our IPs is what's really needed here. And again, it's not about trying to, police hand hygiene and stuff like that. There's so much more to infection prevention that is really designed to make sure that you and our patients stay safe as well. So that's an excellent point. The next question is what are you recommending to use on the ultrasound screen and cart? So great question, Andrew. So again, you want to defer back to the manufacturer's recommendations for compatibility. If your ultrasound machine is touchscreen, there's a high possibility that there's nothing that is quote unquote compatible with it because touchscreens are historically problematic for disinfectants. As a potential workaround, you could contact the manufacturer and ask them if they have anything they recommend. And if they don't, or they're unable to provide that recommendation, you can always use I would not use a bleach product for one, but you could use a higher alcohol disinfectant wipe it down for the contact time. So if it's 2 minutes, whatever, and then take a wet paper towel that's just moist and wipe off the residue from the disinfectant after the contact time would be probably the best possible fix. Again, that could potentially cause your screen issues, but if you're really dealing with these patients, you want to make sure that you're safe. The other potential is to look at some type of screen cover if those are available commercially for your manufacturer device. The next question is, why are so many people in the community using the droplet mask if N95 is required? So number one, it is not, and I want to repeat, it is not recommended that the general public be wearing PPE in public. That is not a recommendation. It's not evidence-based. It's not warranted, and frankly, it's a waste of resources. It is the PPE are for people that are ill and the people that are taking care of the ill people. So again, we're going to put these people in negative pressure rooms if at all possible. We as healthcare professionals are going to wear an N95 respirator mask. The surgical mask that the patient wears is probably very effective. But again, as healthcare professionals, we might be exposed to other sort of things like aerosolization and stuff like that. And so CDC is acting out in an abundance of caution. If you go to the WHO website, they specifically address airborne and really don't say it's a risk. but again, until we have a full handle on complete routes of transmission, they're handling this very, very similar to what they've done for Ebola and SARS and MERS, again, to make sure that we're safe. Now, if you don't have access to an N95, could you use a surgical mask? Certainly you could, but that would not be ideal. And so again, that's where I'm saying if you are doing these high-risk procedures, work with your infection preventionist, establish sort of a tiered system, which most IPs are working on right now, to say who needs what urgently, or can we sort of relocate people to certain units in order to maintain this. I know I was at a hospital Saturday and I asked for a mask because I had a patient with the flu, and it was like an act of Congress getting a mask. I mean, I literally had to sign a form why I needed it. It was completely ridiculous. And so we want to make sure that we do that. Another great question from Deborah is, can we wear our prescription glasses or should we absolutely wear goggles? This is an awesome question. So prescription glasses alone are not an OSHA-approved means to prevent mucosal transmission. So you want to make sure that you are wearing some type of healthcare rated eye protection. Goggles are fine. They're not comfortable at all. Honestly, what I would consider for vascular access is a shield. So you could wear your regular mask underneath your N95 mask and then have one of those face shields that comes down with the foam from the top. Those are far more comfortable. They're anti-fog. So think about the work that you're trying to perform and then use what you have access to, but that would be my personal preference because it's going to give you that clarity that you need for the type of clinical procedure that you're performing. The next question is does hydrogen peroxide as a germicide work against COVID-19? Again, I would defer you. There are different concentrations of hydrogen peroxide. Hydrogen peroxide, bleach, quaternary ammonium, and alcohol are all very, very effective things that can be used. And so you can go to that EPA list, which Judy will send out, click that link, and you can either look up at the product by the name or the EPA registration number, which will be found on the product itself. And if it's on that list, you're good to go, you're golden. If it's not on that list, I would recommend trying to get a product on that list. But if it is simply not available, then CDC and FDA and EPA have said, use what you have. It'll be more effective than not. The next question is, my hospital is trying to be conscious about saving masks. When doing a dressing change, is it imperative that the patient wear a mask along with the practitioner? This is for a person not suspected to be infected. So, I would go back to our standard of care expectations. If our standard of care is to have the practitioner and the patient wear a mask, then we don't want to deviate from that standard of care. Now, is there any reason that a patient, if they're going to be in the facility, let's just say, 2 weeks, hypothetically, there's really no guidance that says the patient's mask can't be reused for them. And there's other things like physical barriers. You could put up a drape. There's lots of different other things that you could do besides using a mask. I'm thinking similar to like an anesthesia setup where the head is covered behind a drape. There are other ways to skin the cat that you might have to get a little MacGyverish with, but that would be something that I would consider with that. The next question is, how severe should the symptoms be before one goes to the doctor or gets tested for the virus? So right now, if you look at the symptomology of this, if they're fever, they've got cough, those types of things, they should go get screened. We would probably not say that unless we were not acutely aware of potential community transmission. And again, it's not to say that the majority of the things that present to urgent cares and EDs are going to all be COVID. The most likely they probably will not. But it is out of an abundance of caution that we want to make sure we can stop this community transition or transmission out there. So the symptoms don't necessarily need to be severe. CDC guidance actually says if your fever is above 100.4, you want to also stay home from work. So I'd sort of use that as a threshold as well. Do you recommend using an N95 respirator mask for any respiratory patient? Again, if the patient is suspected of having COVID-19 infection, yes. If it's just a general respiratory patient, then no. Especially if the circuit is closed and everything is functioning correctly with that. Now, if I'm a respiratory therapist and I'm coming in to do a neb treatment, then I might consider that. But right now, there's no specific clinical guidance that says for those types of procedures with non-infected or non-suspected patients, we don't need to use an N95 as of right now. The next question is about the corticosteroid use. have physicians and practitioners prescribed and been advised of this. This has been something that's been embedded in the CDC healthcare alert networks that have gone out. You can certainly provide that to your clinicians that are prescribers. I know CDC has mentioned that in the conference calls. They published it in both the WHO and the CDC clinical guidance document as far as treatment. And again, it's mostly supportive care with the exception of the people that got this experimental drug, but you could certainly share that with them. The next question is do you develop immunity post-exposure? Awesome question that we don't know the answer to. So there's they do think that there's a low risk of acquiring this if you were to have it, but we're not 100% sure on immunity since this is a novel strain. But those are questions that they'll probably have pretty quick answers to here shortly as they do additional specimen testing. How long does the virus survive outside of a host? Again, this is something that they're experimenting with right now, but we think, a couple days. Again, the great news is that this virus is very easily killed by your hospital-grade EPA-registered disinfectant. It's very effectively inactivated with hand hygiene with alcohol-based hand sanitizers, and we can stop it from coming in our mucosal membranes through the use of PPE. So we've got a lot of great solutions that we do that. The next question is, do we have a protective cover recommendation to put over medical equipment such as ultrasound or vein visualizers after cleaning and disinfection and in between patient use? So again, we don't really need to change a lot of what we're doing. We simply need to up the ante, if you will, with ensuring that after every patient encounter, we're disinfecting our equipment. I would be pretty bold in saying that I think if I came to most hospitals, we would find some breaches in this practice. Not with the people on this call, but we know that our colleagues are not always the best about doing this every single time. So if you add a barrier, then you add additional layer of what has to be cleaned and removed. So I'd be a bigger proponent of actually cleaning the machine after every single use and not adding additional things. For example, with Ebola, we know that when we added additional PPE, it became problematic for staff. And so more is not always better. And if we can sort of engineer a program and a process that's going to work for us, that would be better to do than nothing else. The next question is, are there CEUs available for this? Absolutely. Judy's going to go through that information here in just a second. And it looks like we have two more questions. Let's see. How much is the cost of the diagnostic test for the patient? And does it have reimbursement or some type of government support? I honestly do not know. I know that right now the testing kits have been provided to the states at no charge to the states. It's a CDC federally funded thing. If you've watched on the news, President Trump just signed, I think it was $8.3 billion, if I'm not mistaken, into law that was passed by Congress for additional funding. So as far as I understand it, there's no direct pass-through costs if it's a state lab test. Now, if a clinician orders the test through a reference laboratory like a Quest or a LabCorp, then I imagine there will be normal testing fees and services that would be billed to insurance for that. I don't know what the federal government, if any's, response to that will be, but that would be outside of the scope of my knowledge. And then lastly, let's see, is there a distinction between allergy symptoms and COVID-19 symptoms? How do we know if patients' symptoms are related to chronic allergies with the season rapidly coming on? So that's a great question. And honestly, I'm a huge allergy sufferer. So this is something that's personal to me. A good history is going to help us understand that. So if we have a patient that is presenting with, chronic sinusitis or something like that, and they have a positive history for chronic allergies and they're on medications, and certainly the seasons are now changing and things are blooming, that gives us a pretty good indication that it's related to that. Now, if that patient is febrile and has a cough, then my sort of radar suspicion is going to go up a lot more. So I would ask good history questions, and then certainly you can do diagnostic testing now as well, so that you've got that. And then the last question is, what are your thoughts on domestic air travel? I think that if you are an older person with lots of comorbidities, I would probably steer away from that. I would certainly not recommend necessarily going to a massive event where there's no hand hygiene being performed. Would I feel safe going to a conference where there's a high attention to infection control? I personally would, yes. Have I gone out and bought every ounce of toilet paper and the Costco? No, I have not, because again, I treat this as just another event in the sort of the infectious disease timeframe. So I think we want to be very, very cautious about our response to this. But I would feel very comfortable getting on a commercial airplane in the U.S. They have good HEPA filtration. I would encourage you to take some hand sanitizer with you, and it would not be a bad idea at all to disinfect your seat and your tray table. Other than that, those are honestly things that I do every single time I fly, and I fly a lot. So I would not steer away from things like that that you can make reasonably safe. We don't need to live in a world of fear. We need to be pragmatic about this approach, and we need to use all available resources and knowledge to protect ourselves and our patients, but we also don't want to overreact. So hopefully that answers the question. I think we went through 49 questions, Judy. So with that, I know we're a few minutes over, but I wanted to ensure that everyone's question was personally heard. And Judy, and I'll turn it over to you to do your closeouts.
Well, thank you, Hudson. That was great. I really appreciate your time and expertise on this. So I did want to remind everybody that we also have a couple more webinars coming up. So on March 25th, Lee Steer is going to be talking to us about one stick for PIV access. And then on April 21st, Jocelyn Hill will be talking about how to treat those patients that have substance abuse problems and what some of the indications or concerns are with vascular access devices. So both are free webinars, both have CE attached to them. So I hope to find you at our next webinars as well. So with that, again, Hudson, thank you so much. This was a great webinar. I appreciate each and every one of you that have attended today, and we'll see you at the next one. Thanks so much. Bye now.